Well, good morning, everyone. These will be your glasses. Anyway, I'm sure all of you are familiar with the State of Aphasia report, which was published last year as an advocacy tool, a resource, 125 pages just chocked with data. But the report really was not the end goal. The end goal is to address the recommendations that evolved out of the research for the report. And so that's really our purpose here today, is to move from the data to recommendations and to see how we can address those recommendations. So the process that we're going to go through this morning is I'm going to address each of the 10 key topics and recommendations, pulling some of the data from the report. As we go through, be sure and jot down any ideas that you have for your table or for other tables. And then your table will discuss the assigned topic. A representative from your table will present the summary of the discussions. So I'm just going to launch in to the first topic, which is frequency of aphasia. When you report frequency of aphasia, what statistics do you use? Whether you're applying for a new program, writing a grant. The NIDCD reports on their website that about 1 million people in the US currently have aphasia, and that's data that's extrapolated from stroke. ASHA cites the 1 million prevalence estimate of the NIDCD. The NAA website uses 2 million as a prevalence estimate, and the American Stroke Association gives no frequency statistics for aphasia. About 1.5 years ago, Aphasia Access began reporting, based on the data from the white paper, that a conservative estimate of prevalence is approximately 2.5 million people in the US living with aphasia. And that data is based on extrapolations. It was checked by an epidemiologist and considered suitable estimates. And here you can see information on how the data were arrived at. So approximately 2.4 million is the low estimate, up to 4 million is the high estimate, which we aren't using because we want to go with the conservative estimate. But why are critical organizations all reporting different statistics? So that's our first question to consider. A little more about frequency. Here's a table, and I don't expect you to be able to read all those numbers, but this is what's in the literature about the percentage of people with stroke that have aphasia. Lots of research. The range in those studies was 24% to 50% of stroke survivors present with aphasia. More recently, Charles Ellis and his group have come out with a study that says 14% of people with stroke have aphasia. And right about the same time, Mitchell and colleagues came out with a study that said 42% of people with stroke have aphasia. So what do we believe? Most people just kind of pick a middle number and report it. Probably the reason for this wide range is that the samples vary in time post-onset, stroke type, sample size, the setting. So some of these are hospital admissions, some are down the road, more chronic people with aphasia, the sources of the data, and also the assessments that were used to collect the data vary from very crude screenings to full-on evaluations by speech pathologists. And finally, studies derived from different countries. So you've got all these different ways of measuring the frequency of aphasia. So what percentage do we use to validly reflect the frequency of aphasia among stroke survivors? That's really an important question. Another issue is that aphasia prevalence data tend to be restricted to the stroke population. We don't have data to address other etiologies of aphasia the way we do for stroke. So people with focal brain tumor or focal traumatic brain injury that have a frank aphasia don't get represented in those statistics that we're using. And so by estimating aphasia frequencies associated with other etiologies as well as stroke, we really increase the prevalence markedly. So this is important, but why? Y'all notice that I'm kind of dog crazy. That's the most fun, is going through picking out dog pictures. Most aphasia stats around the world that draw only from stroke data are underestimates of the prevalence. Use of different statistics by different people or different organizations create confusion, like the American Stroke Association. They just gave up on reporting prevalence because it's like, well, we don't know. Funders and policymakers often look at prevalence and incidence to guide funding and resource needs. So the more accurate our prevalence data are, the higher they are, the more likely we are to have a picture in the big funding arena. Also, I think there's a backward effect that limited attention to aphasia in other etiologies means that not only do we not know what the frequency is, but they tend not to get press relative to outcomes and interventions. So when I was doing the research for the white paper, I found very little on specifically on aphasia in TBI or brain tumor or some of the less known etiologies. So recommendation number 1, address discrepancies in reported frequency of aphasia. And these are just a few things I've thought of. I hope y'all will think of a lot of other things. So how can we coordinate the data reported across organizations so that we're consistent? Is there a way to collect valid data on aphasia more systematically within and across countries? So could we use protocols or something? How do we systematically collect data on various etiologies of aphasia? Let's move on to the next topic, awareness of aphasia. There are about 20 public surveys on aphasia awareness and knowledge in the literature. Awareness is typically defined as having heard the word aphasia, and knowledge is defined as knowing something about it, like it's due to a stroke or it's a language disorder. So the standard is very low for what we consider knowledge of aphasia. And these are just a sample of some of the aphasia awareness surveys that are out there, and you can see that even though awareness varies, basic knowledge, all of those that I've listed here, and in fact all of them in the literature, are below 10% of the public have any knowledge of aphasia. And what about changes over time? Well, in 2002, a public survey showed about 14% of people had heard the name and about 5% knew what it was. 14 years later, the NAA did a public survey of aphasia, and they found about 15.5% had heard the name, about almost 9% had a basic knowledge of aphasia. So to my way of thinking, this is not much of a change for 14 years. The same thing happened in the UK. In 2002, about 14% awareness, about 5% basic knowledge among the public. And 16 years later, 34% awareness, but still 5% basic knowledge. So there were increases in awareness in England, but simply having heard the word aphasia is not sufficient. And the reason I say that is if you read these articles, you see that when people were asked, have you heard the word aphasia, and they said yes, then they were asked what it is, and they said things like, it's the same as Alzheimer's. Aphasia is a skin disorder, some sort of mystical creature, a form of pre-leukemia. Would that be half aphasia? So, having heard the word doesn't really help us very much. We need basic knowledge of aphasia. And why? Why does it matter? Lack of public knowledge has major consequences. It influences the level of financial support for services and for research. It's associated with inappropriate referral or inadequate management. It reduces public acceptance of people with aphasia. It impacts social relationships and reintegration into the community. It reduces access to services, and it inhibits access to information and resources for people living with aphasia. So, my thought, oh, this changed around, is enough already. We know that people don't have awareness or knowledge of aphasia, and that aphasia awareness is important. So let's do something about it. It's time to move past the statistics that tell us they don't know and do something to make the statistics say they do know. So recommendation number 2, improve public awareness and knowledge of aphasia. And I believe, as y'all talk about it at your table, you can decide if this is true, that it really requires a systematic and collaborative inter-organizational strategy. And it requires understanding what catches the attention of the public. So right now we have awareness programs that are very interesting all over the place. What is it that really works is what we need to think about. The next topic is funding for aphasia services, and I almost left this one out because it's a big mountain to climb, but I thought, oh well, it's probably one of the most important mountains. The World Health Organization says that parties should undertake to ensure people with disabilities are able to access health-related rehabilitation to enable full inclusion and participation in all aspects of life. International best practice guidelines say people with aphasia should be offered intensive aphasia therapy designed to have a meaningful impact. And people with aphasia benefit from intervention in the acute phase and in chronic phases. The WHO also considers health financing one of 6 building blocks of the WHO framework for action to improve health services. However, studies have continued to show that stroke rehab remains underfunded relative to the scope of the challenge. And the problem is magnified when we think beyond stroke to consider the impact of communication disability on the lives of people with aphasia and family members. 42% of stroke patients were not referred for rehabilitation after acute care in one study. And this was compared to an earlier non-referral rate of 31%, so it actually got worse over time. Only 32% of Medicare-funded stroke patients were referred to home health, and only 31% of stroke survivors in a different study were referred for outpatient rehab. In the VA system, only 30% of people with aphasia received speech pathology services in one study. And we know that even after referral, most funding sources limit the duration of therapy and the number of sessions. So referral isn't just the end. Lengths of stay in acute hospitals are short. Aphasia is often not the priority during that acute care and also during rehabilitation stays, because people are going to rehab so quickly that often those medical needs are still a priority. Swallowing often takes precedence in acute settings. So 77% of assessments in acute care were for swallowing, according to an Aphasia study. And another study showed that dysphagia was the main caseload for 89% of clinicians in acute and 78% of clinicians in residential settings. Aphasia is considered a chronic condition with ongoing needs over the long term. There's substantial evidence that therapy works for chronic aphasia. A study investigating long-term community services, and this was for people with stroke in general, found that gains in meaningful activity for people with stroke took at least 1 year to achieve. However, there's minimal funding for services in chronic aphasia. So how are we going to get those meaningful outcomes if services are limited? Most funding is available during the first weeks or months after the onset of aphasia. So what happens over the long term? Well, most of the service delivery models that we have right now are university clinics, aphasia centers, intensive comprehensive aphasia programs, but the availability of those kinds of services are highly varied. In a study that Audrey Holland and I did, we surveyed aphasia centers in 2010 and then more recently in 2016, and there was really a minimal net increase in the number of responses to the survey. Now that doesn't mean that there aren't centers out there that weren't captured, but it makes me wonder, is it really increasing? Funding and sustainability remain barriers for chronic delivery models. And we know that the consequences of inadequate rehabilitation and long-term support are things like increased medical incidence, hospital readmission, higher levels of care, higher financial costs, increased distress for people with aphasia and their family members. So recommendation number 3 is to increase sustainable funding sources for aphasia services. And some thoughts I had, and hopefully you'll have some others, is a political action committee or something similar a viable goal? Are there alternative funding sources that are sustainable? Should aphasia advocates work with other long-term disability groups? Or should services be reconfigured to give better care within the funding constraints? Let's move on to the next topic, and that is specific services for aphasia. In the white paper, there are multiple domains of aphasia services that were identified as needing improvement, but I want to focus on 2 under this particular topic: mood and depression, and participation in activities in life situations. So, aphasia and depression. This is a quote from Kyla Hudson's work when she interviewed people with aphasia. One person said, "I get very depressed, very emotional. It's hard, yeah, I find that really hard." So how do you address depression in your aphasia practice? We know that 93% of stroke survivors with aphasia versus 50% of stroke survivors without aphasia experience high psychological distress at 3 months post-onset. 65 to 70% of people with aphasia experience depression at 3 months, and depression tends to persist at 6 months. The frequency of major depression increased from 11% at 3 months to 33% at 12 months in one study. Depression is associated with decreased quality of life, poorer overall health, lower functional outcomes, poorer recovery, higher healthcare costs, longer hospitalizations, increased mortality. In fact, in a study by Worrell and colleagues, psychosocial factors such as mood were the highest predictors of living well with aphasia in the first year post-onset. So depression and anxiety are also significant risk factors for stroke. There's a twofold heightened odds of stroke among people with aphasia and a 34% higher risk of stroke for developing a subsequent stroke among people who are depressed. So what's the message here? SLP should be involved in identifying anxiety and depression in patients. And there are very simple, quick tools out there to screen for depression. SLP should address counseling needs at an appropriate level of a stepped care hierarchy. And Linda talked about this in her 7 Habits yesterday, the work that's been done by Caroline Baker and Ian Kneebone on a stepped care hierarchy. So at those first 2 levels of a hierarchy where people have sub-threshold depression or mild to moderate mood impairment, we should be doing something about that. So for example, we can target typical causes of depression in people with aphasia, such as social isolation and loneliness, lack of participation in meaningful activities, unskilled communication partners. We can create interprofessional programs designed to prevent depression. Okay, let's move on to the other service in this category that I wanted to talk about, and that's participation. How do you include participation in aphasia management? This is a description Susie Parr gave. Jean was very reluctant to leave the house, even to go on an outing with her husband. He felt she was frightened and expressed his own frustration at being cooped up. We've all heard these kinds of stories. People with aphasia participate, on the whole, in fewer activities after onset. Pastimes often tend to be sedentary and lonely activities. In fact, participation in valued activities is associated with living well with aphasia, higher quality of life, better overall health, and the flip side is also true, that lack of participation is associated with depression. However, there's limited attention to participation outcomes across the profession. Assessments continue to emphasize language and impairment outcomes. Now, I don't think this is true for this group, but for the larger group of people working with people with aphasia, there was a survey of top rehab facilities. Only 23% of the respondents reported assessing participation outcomes. And even then, the measures that they gave for participation were not really participation measures. They were things like ratings of communication disability, not what people were doing in their daily lives. 3 studies of goals in aphasia management showed very minimal attention to participation. So you can look across these 3 studies, 6% of goals, 8% of goals, 5% of goals addressed anything that fell into that participation domain. Treatments largely focus on impairment and basic functional activities. A survey of SLPs in North America showed that 13% of inpatient treatment time and 15% of outpatient treatment time involved some kind of participation-oriented intervention. But there are barriers to addressing participation. The medical culture of healthcare, lack of formal tests for participation outcomes. Lack of treatment protocols that help clinicians understand how you can do this kind of intervention in acute care, in rehab settings. Difficulty getting outside of the clinic to more authentic settings. Funding that's limited to medical necessities. Someone mentioned yesterday, how do you write goals that Medicare will fund? Time limitations and productivity requirements. So whoever's at those tables, these are the barriers we have to overcome. So recommendation number 4, implement improved services for people with aphasia, including management of mood and depression and attention to participation in life activities and situations. The next one is social relationships. How do you address friendship in your aphasia practice? Ronald refused to attend social functions and withdrew from her favorite pursuits. Carol, his wife, described their lives as barren and depressing. Aphasia is associated with reduced social contacts and social networks. Loss of friends is a widespread consequence of aphasia. People with aphasia are significantly lonelier often than non-aphasic controls. One study of 83 people with aphasia found 30% could not name a single close friend. That's heartbreaking. Imagine if you had no friends. A higher frequency of contacts with friends and higher number of friends are related to better health, greater life satisfaction and well-being, higher quality of life. And over time, few friends or social contacts are associated with loneliness and social isolation and a strong predictor of depression. Social isolation and loneliness are associated with lower well-being, higher incidence of physical illness, higher rates of depression, higher level of disability, higher rates of premature death, greater cognitive decline, higher healthcare costs, and the list goes on. It's really bad to be lonely and isolated. It's not just, oh, poor them. It's a truly significant health issue. You've probably seen these statistics from the white paper or some of the presentations. Social isolation and loneliness increase the probability of disease or death by 200 to 500%. Reduced social relationships is a risk factor similar to obesity or alcohol abuse and equivalent to smoking up to 15 cigarettes a day. I think those are astonishing. The message, management of aphasia should go beyond language impairment to assess and improve social engagement. And how do we go about that? We directly target social relationships in aphasia management. It doesn't mean you have to give up impairment-related therapy. It just means you need to think beyond the results of that specific task by reconfiguring goals. So for example, here's a typical task we might have. JB will write 5 sentences to describe pictures. Well, if we reconfigure that, it could be JB will write an email to a friend consisting of 5 sentences to describe photos of her birthday party. Now you've pulled in a social relationship. You get the same impairment outcome, but it's meaningful. It has some social weight. We can directly target social relationships by using buddy systems. This was John Lyon's work from a long time ago. Volunteer mentors who we might pair with people with aphasia. There's a big push towards befriending programs. There's a huge project going on in Britain called Superb, supporting well-being through peer debriefing. Befriending, not debriefing, befriending. I might have just come up with a new thing. But they're training people with aphasia to befriend other people with aphasia. So that's another approach. Social network intervention. I was, talking about this like in the 1990s. It's really a way of going about identifying people who might be a friend. Aphasia groups, and I don't need to preach this to you all, but the potential of aphasia groups for developing relationships is really rich. Using social media as the context for therapy, and I think we saw that yesterday in a lot of the presentations, how social media, I love the telekaraoke. That was cool. Drawing from the large literature on evidence-based methods of addressing social isolation in the elderly. There's lots of work going on there. So we might pull from some of that. But basically, the recommendation 5 is develop and implement services to prevent social isolation in aphasia. Let's move on to family and caregivers. What family services do you offer? Education and information provision, counseling, signposting to other services, communication partner training, and there's a difference between just giving people some do's and don'ts or a quick brief overview versus a full-on evidence-based partner training intervention. This is a quote from the wife of a man with aphasia. Edgar was so happy to be going home. The staff were all congratulating him, but I was terrified. All I could think was, oh my God, what now? Families are part of the rehab process. Close family members experience changes in relationships, health and well-being, employment, roles and responsibilities, participation in social life, emotional well-being, marital satisfaction. Changes in family member functioning is consistent with the concept of third-party disability, which is the negative functional impact of a person's health condition on their caregivers. So it's actually a disability that's the consequence of your loved one's health condition. Best practice guidelines recommend that family members should be included at all stages of aphasia rehabilitation, receiving information, having their own needs met, getting trained to communicate with the person with aphasia. They should be referred for respite, medical or counseling services, and it doesn't just mean simply sitting in on therapy sessions. That's not what including at all stages of rehab means. It means addressing those needs. Do they get what they need? Apparently not. Family member services are limited. Across 41 patients with aphasia, one study found that only 3 out of 137 goals even mentioned family. In interviews with SLPs, they rarely reported goals for family members. Resources and models for family-specific services are extremely limited. Rehab services tend to focus almost exclusively on the person with aphasia. So family education, even if we do that, it's about the person with aphasia, not about what the family member needs. And we've found many times, sort of like aphasia awareness statistics, that information needs of family members are not being met. Family communication training needs are not being met. To me, the lack of communication training from family members is a substantial and astonishing gap in our services. I think Roberta Ellman has talked about some personal experiences with families who had had aphasia treatment for an extended period of time and never did anyone mention ways to communicate with their family member. Well, speech pathologists report barriers to providing services to families, such as they consider rehab is about the person with aphasia. There's not enough time and resources. Funding is specific to the person with aphasia. There's a lack of family member availability often when the person is an inpatient. Some feel that it's not a legitimate role to counsel family members, or they don't feel well trained in counseling or communication partner training. But recommendation number 6 says that regardless, we have to improve services for family members and caregivers. They're part of the outcome. Are there creative ways to deliver these services, such as e-learning or groups? I know some of you have done some very creative ways of delivering those services. Are there ways to collaborate with other professionals or team members to make sure that families receive aphasia-related services? How do we make sure that family needs are met? Can we audit family services? Let's move on to the next topic, communication access, which has been defined as having the means, supports, and opportunities to communicate effectively, meaningfully, accurately, and authentically in order to get equal, uncompromised access to goods and services. This is really related to what was being talked about yesterday in health equity. So communication access in healthcare is one area under communication access. We know that successful patient-provider communication correlates positively with patient safety, patient satisfaction, positive health outcomes, and on and on and on. There's ample evidence that communication can be improved by implementing relevant supports for people with aphasia, and projects have succeeded in integrating communication supports for aphasia into a variety of healthcare settings, so it can be done. Other vulnerable populations also profit by communication support. So it's not just aphasia, and that's important when we're approaching at a programmatic level or an administrative level. The number of people's lives that would be enhanced by implementing patient-provider communication and supports is staggering if we really look at some of the statistics. However, people with communication disabilities continue to report low levels of satisfaction with their health care. People with aphasia and families also report negative health care experiences, largely due to communication issues. Here's a quote that Laura used in one of her talks from a lady who is describing her experience in healthcare and acute care, and she has recovered down the line. I know they meant well, but I was completely overwhelmed. It was talk, 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 and I couldn't make sense of it, and I couldn't ask questions. So let's dig deeper into communication access. Medical error is the third leading cause of preventable death in the U.S. 50 to 70% of adverse hospital events are preventable. 60 to 70% of adverse events are attributable to poor communication. 2/3 of studies examining fall risk identified communication disability as contributing. 18.3 million medical visits would not be needed if good patient-provider communication occurred. In a survey of top-rated rehab facilities, again, the survey I mentioned before, 85% had no written policy regarding patient-provider communication. 85% did not include patient-provider communication in quality improvement or audits. 62% reported no mandatory staff training in how to communicate with people with communication disabilities. And approximately 50% reported no use of adapted or aphasia-friendly written materials. I was really astonished by this result. So what's the status of patient-provider communication in your healthcare system? Is it, really bad or really good or somewhere in the middle? Some solutions that we might think about, and I hope you all come up with some outstanding ones. Considering creative methods of integrating partner training into healthcare systems, drawing on the implementation literature to help change the system level or the culture level of healthcare, recruit other organizations to press for mandates. I think it was mentioned yesterday that when it comes from the voice of people with aphasia or people with communication disabilities, it's very powerful. Create a national aphasia awareness campaign targeting communication access in healthcare. So recommendation number 7, improve communication access in healthcare and the wider community. Let's go on to talk about monitoring the quality of our services. Patients with stroke-induced aphasia incur higher healthcare costs than those without aphasia. Outcomes for people with aphasia are poorer than outcomes for stroke without aphasia. Aphasia is associated with higher rates of hospital readmission than stroke without aphasia. People with communication disabilities are 6 times more likely to have costly adverse medical incidents. Poorly coordinated discharge plans resulted in 29% of patients being readmitted, and the list of consequences of inadequate care goes on and on. Monitoring aphasia services could reduce consequences of inadequate care. So promoting quality services can take a variety of forms, like having management protocols, like nursing does, conformance with best practice guidelines, discharge checklists that are used universally, audits of services. And there may be some places that are doing this that could share their resources. All hospitals have programs for continuous quality improvement, which involves collecting targeted data to monitor care. There are many online manuals that describe the process of creating QI criteria. However, to my knowledge, communication disability is usually not included in those QI criteria. The U.S. Agency for Healthcare Research and Quality does provide priorities for healthcare quality, and we should apply these as key elements of quality aphasia services. And these are ones that I think are particularly relevant. Reducing harm caused in the delivery of care, getting the family and the person engaged in care, promoting effective communication, widely using best practices, developing new healthcare delivery models. All those are things we've been talking about, but we need to look at them in terms of how do we audit that those are being done. What are the key indicators of quality care in aphasia? And I'm going to say something that probably sounds controversial, but it's not about evidence-based practice. You can do constraint therapy and you're doing evidence-based practice and not be delivering quality care. So it's a much bigger picture than that. So we need to think about the big umbrella of what is quality care. How can we apply current QI concepts to really know what quality care in aphasia is? Co-design of programs with the people, the stakeholders that involve, having patients provide assessment of quality care, greater stakeholder engagement at all levels, and auditing beyond things like numbers of patients or numbers of diagnosis or simple satisfaction questionnaires to look at outcome, process, content measures. So recommendation number 8 is to identify and implement mechanisms to track key features of aphasia services for quality improvement. Let's go on to research in aphasia. In 2015, Ora and I presented a paper on the research gaps that we identified, and we found insufficient high-quality research across a bunch of categories. And I did just a quick perusal of the research to date, and still I find no high-quality research that addressed those big issues, life participation interventions at a big level, So it's, even though there's a lot more research out there that informs us, those big gaps remain, and we have to wonder why. Maybe it's too soon since 2015, because the complexity of those big research questions are heavy. The designs are difficult. There's maybe a lack of researcher capacity in those areas, a lack of relevant outcome measures, lack of funding for this kind of research, and I really believe that that's truly one of them. Are major granting agencies addressing the gaps? And this is a very shallow look, but the National Institutes of Health funding for aphasia research in 2018 was $36 million. Well, cannabinoid research got $148 million. That doesn't seem right. A perusal of 2017 funded projects suggested that only 2 out of 98 projects, just by the title, had some relationship to participation, conversation, or something similar. Now, surely, maybe some of those had outcome measures that were important, but that's, you would think that there would be at least some that looked at the impact on participation specifically. So are we clear on our research priorities? What are the key questions? What do people with aphasia want to be studied? Can we involve people with aphasia as research partners? And Jackie talked about this yesterday, and so did Lisa. There are some resources available on the internet, and Jackie says that there'll be more available as time goes on. Can we develop better North American collaborations? We should be embarrassed. I mean, Australia just got their second multi-million-dollar grant for a Center of Excellence in Aphasia, where they bring in researchers from all over the country. The collaboration of aphasia trialists has had millions for aphasia research in the EU. So why don't we do that? So recommendation number 9, increase research to determine what works to ameliorate the impact of aphasia on life participation and quality of life. The next topic is creating change. Change will require a concerted effort across organizations and key stakeholders. We know that funding and resources are limited, so we're going to have to come together and act together to transform the lives of people with aphasia. Organizations tend to go it alone. There's that fear of being overshadowed by partners, or fear of losing funding to someone else, or just not enough time to develop those partnerships. Organizations and stakeholders often don't know what others are doing. Many organizations duplicate efforts. So we ought to look at creating alliances across organizations, identify relevant organizations or key individuals, and a process for creating alliances. Capacity building is important, ensuring that all related organizations understand aphasia and understand the needs of people living with aphasia. And looking beyond aphasia and stroke organizations. Can we raise the visibility of aphasia in TBI, in other domains? So recommendation number 10 is collaborate across organizations and systems to recruit best available resources for aphasia and other communication disabilities. So there's much to do. So are you feeling depressed? No, this is an opportunity. It's really a tipping point. I mean, over my career, I've never been so happy and excited. I really see change happening. For the first time, I feel that we're addressing those big questions. We're talking about people with aphasia and not research design. So where to from here? Back in your court.